Hi, this is Mrs. White. This is the respiratory unit of NU214. In this unit, we want to be able to explain the care of patients who are experiencing epistaxis, recognize and evaluate major complications of upper respiratory infections, describe the care of a patient with a tracheostomy, describe the nursing management of patients with oral, head and neck, and laryngeal cancers, and then use the nursing process for care of the patients undergoing a neck dissection. This is just a review of the upper respiratory tract, which is where we will start today. Little picture here to remind you of the different functions and features that are involved in the respiratory system in the upper part, including nasal sinuses, paranasal sinuses, but we will basically be focusing our attention on the oral cavity, larynx, trachea, and the nostrils and the nasal passageways. So the first thing we're going to talk about today is the nasal fracture. There are some hallmarks for a nasal fracture, also known as a broken nose, and you can see them listed here. Among those would be deformity, always possible to have a bloody nose or epistaxis because of the trauma that's incurred, usually with a nasal fracture. Additionally, the nasal passages are full of vessels, and many of them are at the surface. Crepitus is that sound, as if bone on bone. Could be swelling or facial edema and ecchymosis. One of the things I want to have you guys remember here is that anytime there's any sort of trauma to the head, one might be concerned about a cerebral spinal fluid leak. And that is something that you should always keep in the back of your mind as a potential sequela from any sort of trauma. What it looks like is pink, usually like a light pink drainage. If you put a gauze and collect it, it makes a halo. And we used to do some bedside glucose testing, but lab confirmation would be more accurate. So anytime somebody has a nasal fracture, our other concern, of course, is airway. And this is why it's important to sit the person upright. Ice can be given for the swelling, Tylenol, of course, for the pain. Decongestions like phenylephrine, especially if there's bleeding, and also to keep the nasal passages open. What we do ask people is to avoid hot showers, alcohol, and smoking after they've experienced a nasal fracture. And depending on the severity of the fracture, most will heal on their own. However, some have deformities that do need rather immediate surgical correction, especially if the airway is impaired. And the folks will go on to have corrective surgery down the line, more for cosmetics or restoring their functionality. So that's what we'll talk about next. So nasal surgery can be done for a few different reasons. Chief among them would be correction of some sort of a deformity or underlying issue like deviated septum. We do things like turbinate reductions for people with sleep apnea and snoring. And rhinoplasty is a bit more cosmetic. Septoplasty, more important to breathing and congestion. So the nursing care is listed here. Preoperatively, of course, avoiding aspirins and NSAIDs before and after. And that, of course, is for the risk of bleeding. And why smoking cessation? It's a good idea, of course, but nicotine is a vasoconstrictor. So impaired blood flow will delay healing. So this is why people who have nasal fractures and also now nasal surgery we have them avoid smoking. After surgery, the person does present as if they have facial trauma a lot of times because the surgeries are rather traumatic. They could have edema, they could have bruising, and the teaching is there. It's mostly comfort measures, always concerned about the airway, so the head of the bed should be up. And then, of course, prevention of bleeding. The next thing we'll talk about is epistaxis, or commonly known as the bloody nose. So the anterior ones are the ones that we will see. These are generally self-limiting and easier to fix. And posterior can be dangerous. There can be a lot of bleeding and fast. They generally need to have admission to the hospital. And I have listed here some of the causes of epistaxis, and some, of course, are trauma, some are systemic, underlying health disorders, but many different reasons that one would have epistaxis. So identifying the cause helps us with the treatment as well. The treatment of epistaxis really is depending on whether it's anterior or posterior and how severe the bleed is. Ideally, what we need to do is you need to identify the site of the bleeding, applying direct pressure, which we want the person sitting up and the head tilted forward, which prevents swallowing and aspiration of the blood. And then pinch the soft outer portion of the nose for 5 to 15 minutes. So that's the part that's under that bone. So it does no good to pinch the bone because you won't be stopping any bleeding. May be necessary to have suction to improve the visibility if they're still bleeding. And after that initial treatment, and that's what we teach people at home, right? Most people know how to take care of a bloody nose. If that bleeding doesn't stop after 5 to 15 minutes, and osmosis says 20, but your book is 15, then they need to seek some care, and we usually start with that as well at the hospital. If it doesn't stop, we can often have to look further to see it's maybe not as simple of an anterior bleed, might be posterior. And then once they get to the hospital, we could use cautery by way of silver nitrate. That's one of the meds that we use, and nasal packing is always a possibility. And if that stuff doesn't work, we often will do something called a rapid rhino. So you see that here. Basically, it's an air-filled device. The pilot balloon that you can see hanging down below here, that's where the air is inserted. So basically, it's inserted into the nose, into the posterior airway. You'll see these commonly with posterior bleeds. And then the air is inflated until the bleeding has stopped. And once that does, we don't take it out right away. It has to remain in place for upwards to 2 to 3 days. And with anything, the person is at high risk for infection because of such a dark, moist environment. And think about all the bacteria that are up in the nasal passages anyways. So very common to give those prophylactic antibiotics. And then the patient has to either come back and have it removed, or they might be admitted to the hospital depending on their ability to care for this. And then the treatment post-op, it's not really post-op, but post-procedure treatment is, of course, we don't want to do anything that's going to potentially cause the nose to bleed again. So there are some activity restrictions. One thing to note, that somebody who has hypertension will need more air in the balloon than somebody without. So you basically have to overcome the blood's pressure against the vessel wall. So it has to be higher than that. These are inserted by a doctor and not the nurse. But we do need to know the process, and we do need to know what we're looking for. And to kind of just put it back here, When somebody has a nosebleed, it's always important to look at the back of the throat because we may see blood in the front or we may not. So signs of bleeding would be things like frequent swallowing. People who swallow a lot of blood tend to get an upset stomach. So always check the back of the throat. Make sure they're not. Rhinitis is the next thing that we'll talk about. It basically is inflammation of the mucous membranes, very common. Most of us experience viral rhinitis or the common cold. We can also have some that are basically drug-induced, so certain medications and that we may take can cause rhinitis. Treatment here, usually comfort measures based, saline nasal spray, steam, taking antihistamines, sometimes steroid sprays. The meds are listed here. Some of the more common that you'll see are Singulair for seasonal allergies. One thing to note is this rhinitis medicamentosa. Basically, it's rebound congestion. So if somebody's using oxymetazoline or Afrin, that's a very common thing that people use it all the time. It's available over the counter, so people equate over the counter with safe. However, after use of about 3 days, the person, if they don't use it, end up with rebound congestion. So you'll see people kind of hooked on it because they can't breathe otherwise. So there is a table in your book that has some information about some of these medications. And I always just want to tell you guys to think about the safety aspect of medications. Why would we use a steroid spray over something systemic, especially as people age? And that, of course, is for safety reasons. We can use nasal sprays and such to act locally on the tissues to relieve symptoms rather than giving something like an antihistamine, which can cause drowsiness and therefore put the person at increased risk for falls. So bear that in mind as you're taking care of your patients. That's why we do a lot of local treatments for rhinitis, because just working on that part of the body rather than systemic absorption can be preferred. So this is a picture of a person who has orbital cellulitis. And why this is important is because of how close the airway and the orbits they really are to the brain. So somebody who has orbital cellulitis has a very high risk of getting osteomyelitis. Also, they can affect the brain in the way of meningitis. So somebody who has these signs, so if you look, you could see like an abscess formation in the nair there. When we see these folks, they're pretty sick. Usually they have a fever. They require IV antibiotics just because of how severe these infections can be. And sometimes we don't see this kind of stuff in healthy people anyway. So anybody who's immunocompromised, they are more at risk for this. So something to just note, that if you see something like this, we always want to be concerned about the possibility of spreading of the infection, osteomyelitis, or even into the brain under meningitis. And we have here, basically this is a paratonsillar abscess. A strep mono that can cause tonsillitis can also cause an obstructed airway. This can be very dangerous. So when we're considering patient status, the one thing we really need to know is, how is the patient's airway? Can they manage their saliva? If they're drooling, this is an indication of how much swelling there is. They can't even swallow the saliva. A muffled voice. Anytime anything is muffled, whether it's a heart or just words, we're concerned that there's something that's impeding that. And for us to make sound, we need air to move up over the larynx and out. So if we have a muffled voice, that means the air can't get through. If you were to look at somebody's throat, this is what you might see. You can see how large the tonsils are and the exudate that's there. So these people are admitted to the hospital to make sure that we have control of the airway. They often need antibiotics, potentially incision and drainage of the abscess. And for these patients, a lot of comfort measures as well. We may need topical anesthetics, gargling every 1 to 2 hours. And when we say gargling, it's that salt water, making sure their position enhances their respiration, so keeping them upright, cooler room temp liquids, and of course, no smoking. Peritonsillar abscess can be life-threatening. So that's why we have to learn about it. And as we kind of move down, the next thing we can talk about is tracheostomy. A lot of nursing care is spent learning about tracheostomies. It is guaranteed that at some point in your career, you will take care of somebody who's had one or has one. So the indications really are to bypass an upper airway obstruction. So let's say somebody has that peritonsillar abscess and they have an airway obstruction. We might need to do an emergent cricothyrotomy. Again, that's an emergency surgery, but most trachs are done in a controlled setting. We do them either while the person is asleep in the operating room, or sometimes we do them as what we call them an awake trach, where they are awake, but they are given anesthetics, and this way they have some better control of the airway. The other reason that we would use a tracheostomy would be because of the need for long-term ventilation. We usually give a person about 2 to 3 weeks to come off of a ventilator before we consider the tracheostomy. But after that time, it's better for the patient. It's definitely better for the potential of ever eating, if that's something that they can do. People who are mechanically ventilated generally do not eat, but those who potentially could, as they can wean off the ventilator, it's better for comfort, better for hygiene, and there's a decreased risk of damage to the vocal cords because this sits below the vocal cords. A tracheostomy is much preferred. If you had an endotracheal tube, that tube goes down through the mouth and down and rests. So much more likely to have infection and pneumonias as a result of it. So this here is a side view of a trach tube. The balloon that's showing that shows that this is a cuffed tube. So there are complications associated with having a tracheostomy, and of course that would be bleeding, aspiration, pneumothorax. Subcutaneous emphysema is a sign that there's a leak of air from somewhere. So it could be related to the lungs itself, or so maybe there's a problem with the trachea, but the air is getting into the tissue, and normally that does not happen. More commonly seen in patients with chest tubes or somebody who's on a ventilator that has sustained some sort of barotrauma. Some other complications, of course, would be aspiration, which is due to the change in natural swallowing. And the other thing is, if you look at where that balloon is, that cuff, there's oftentimes secretions that will sit over the top of that. There's always the risk of an airway obstruction, which is why trach care is very important, and making sure that the person's secretions aren't too thick. A laryngeal nerve damage, so this is an important teaching point to deflate the cuff and allow for the decrease in pressure on the trachea. Always at risk for fistula formation, as is tracheal stenosis or stricture. In order to prevent complications related to tracheal stenosis, it's very important that we keep an eye on those cuff pressures, generally 20 to 25 millimeters mercury. They are monitored. We have manometers that we measure when we first put them in, and additionally, there's different ways. You get to sort of feeling how they are. So there's the pilot balloon. When you squeeze it, it will feel a certain way, which it does come with experience, but the objective way is to absolutely use a manometer and deflate that cuff occasionally and reinflate it. Make sure that it's at the right pressure. Now, for the difference between a cuffed and a cuffless really is whether or not the person is mechanically ventilated. So the balloon must be inflated for mechanical ventilation. And when we first put the trachs in, they're cuffed trachs until some healing occurs and we can start to see how the patient is doing. So remember, the balloon must be inflated for mechanical ventilation. This is so that when the air is delivered to the lungs, that it actually goes down there. And the more PEEP that's needed means that there's more pressure needed to keep the lungs open. So we want the air that's delivered through the ventilator to go into the lungs and not kind of bounce up and back over. So cuffless, it's when we start weaning, long-term trach patients, decreased aspiration risk. So people who are cuffless need to be spontaneously breathing. And somebody who has a cuffless trach can make sound because the air is able to come back up and around over where the larynx was if they've had a laryngectomy, or over the larynx if they haven't. So speech is not normal, but they can learn how to speak, and that's an important consideration for our folks with speaking, which we'll go into in a little bit. But that's the difference between a cuffless and a cuffed trach. One of the things I wanted to mention, if somebody has a cuffed trach, you should not be able to hear a sound. So if you are hearing sounds, the cuff isn't inflated enough, or I've had it where I walked in and asked the patient how they're doing, and they talk to me and I can hear them. That's also an indication that the cuff is not inflated or not inflated enough. So with the folks with a tracheostomy, there's a decreased cough effort, so there's going to need to be an adjustment of suctioning based on the patient need. In general, we do not suction routinely. We wouldn't do that at NCLEX Hospital, right? So we would suction as needed. And how do we know it's needed, right? There are different signs and symptoms. So adventitious breath sounds, sudden decrease in their oxygenation. If they're coughing and you can see that they're not coughing it up, I mean, that would be ineffective airway clearance, right? So suctioning is used to clear the airway. Always remember that suctioning is a sterile procedure, and it is not without its problems, right? It can be dangerous, and it can have a negative effect on patients. Done correctly with proper oxygenation, it can clear the airway. So some of the complications are really based off of stimulation of the vagus nerve. And we do tend to do things that stimulate the patient's vagal nerve. So things like suctioning, carotid massage, which we may inadvertently do when we're checking pulses or shaving a patient. Any fecal disimpaction. So for many places, nurses are no longer able to do fecal disimpaction. Only limitations to that would be people with spinal cord injury. So when we stimulate the vagal nerve, one of the things we find is that the heart rate will drop, or they may show a dysrhythmia. And if that happens, if the heart rate drops, you need to stop what you're doing and hyperoxygenate the patient. Also when the person gets hypoxemic, that can cause dysrhythmias. If we use too large of a catheter into the airway, then that can cause atelectasis because there's just too much pressure. So as we apply suction, we can actually collapse the alveoli. Improper technique can lead to mucosal trauma. It used to be we would just put the trach tube down, the patient would cough, and we would keep going until we were meeting resistance. And what we found is that we're actually hitting the carina and causes trauma and damage. We only suction while withdrawing the catheter, never while we're inserting. And this is not the time to be doing those lengthy maneuvers, right? We're in and out. You must pre-oxygenate your patient prior to suctioning. And for spontaneous people who are breathing spontaneously, that looks like a bag valve mask hooked up to 100% oxygen. If they're on a ventilator, we have a 100% oxygen setting. As the person has more of a long-standing trach, oftentimes you'll see that they're able to tolerate suction with very little pre-oxygenation, sometimes none. That is not the standard of care that we would ever use for NCLEX, okay? NCLEX is always 100% pre-oxygenation. So we have to figure out how to let the person communicate that has a trach or on a ventilator. We'll start with this TEP valve. So the TEP valve is, it's actually a surgical procedure. It's often done at the same time that a person has a laryngectomy. And this is for patients with the laryngectomy because folks with a trach, they still have the normal anatomy. But basically, there's a small surgical passageway. You could see it, this little pink white guy that's right here in the sitting in the septum between the esophagus and the trachea. And basically, if the person blocks their stoma, then the air goes up and past where the vocal cords used to be. And the person's able to make speech, right? It's not normal speech. Never can be normal speech, but it is functional speech. Some of the other ways that people talk would be things like esophageal speech. Basically, that's when we were kids, we used to kind of belch the alphabet. I don't know if you did, but I certainly did. It's similar to that. However, the air isn't coming from the stomach. That person swallows the air just down, doesn't put it in the stomach and brings it back up. You can't do that sort of speech until oral feedings have begun, so about a week post-op. It takes a long time to learn it, long time to become proficient. Not really a high success rate, so it's not really used today as much as it used to be. And then the artificial larynx, so let me just go back up here. I kind of had these slides backwards. So we just talked about esophageal speech, and then the electrolarynx is, you'll see that around still. It's not always used these days either, but you'll see it. Basically a mechanical sound, maybe used as a transition. So basically there's vibrations from the mouth and tongue, and the electrolarynx amplifies them. So now on to swallowing. So a tracheostomy with an inflated cuff, you need to have speech-language pathology. They can also help the patient with speech therapy. So speech does language and swallowing. If there is no risk of aspiration, then they'll deflate the cuff with the intent to start feeding. So if the patient needs to have a deflated cuff or no cuff that really comes down to speech and their aspiration and basically what we're doing with the patient, whether or not they're weaning or not. So again, the important takeaway here is speech language pathology deals with the swallowing. They are the experts. They can do testing like barium swallows. They will recommend the diets, and they will evaluate the patient's functional swallowing ability. And they are the ones whose recommendations we listen to. Okay, so this is a passing-muir speaking valve. You will see these for patients who have trachs to help with their speech. Basically, the cap has a one-way air valve in it. So if you put it over the end of the trach, the person can draw the air in through the passing-muir valve, and it blocks the air from going back out. So instead it forces the air up through the trachea. A couple of things with this. We don't let people sleep with passing-muir valves on. The person cannot be mechanically ventilated because it needs to have an uncuffed trach. And clearly, if they're on a ventilator, we cannot put something over the end of it. So these are things that are given out by the speech-language pathologist. And again, that's what they look like. It's very common to see them. Most common that I see where I work are these green ones. So this is just a way that they can speak. And I think we need to just talk about a fenestrated tracheostomy tube. So fenestration, a lot of ours are trachs that we see in the hospital setting are not fenestrated because they're made for mechanical ventilation and more acute, but you may run into these out in the community or elsewhere. So basically, when somebody has fenestration, there's basically a hole that's in the trach tube, kind of at the curve, kind of above the curve maybe. You could see it there. Basically, it allows air to flow up and over the vocal cords. But the thing is that in order to have this person with a fenestrated trach that's functional, the person cannot be at risk for aspiration. So that tells you that you need to have a speech-language pathologist evaluate them as well. So this is just another way to have air move up over the trachea so that the person can make speech. And for this, generally I believe we take the inner cannula out because otherwise the fenestration would not work. It would be blocked by the inner cannula. So guys, this was section number 1. This was you know what? I think I'll continue on for a few more slides, so forgive me for that. Let's talk about oral cancer for a minute. So oral cancer is basically often squamous cell. There are other risks as well, HPV. Dentists are doing the secondary screening, so they're looking for evidence of the disease early. If somebody has HPV, often we'll see it like the lip, side of the tongue, floor of the mouth. Tobacco, of course, is a high risk of cancer. And somebody who does have oral cancer tends to have METs pretty quickly because of the large amount of nodes that are there. And that toluidine blue test, that's a test that can be used basically if the cells take up the color, it makes them more visible to the naked eye. I've never had an oral cancer screening test by my dentist with toluidine blue, but you could see the difference on how it's visualized. But this is one of the reasons that it's so important that our patients have screening for oral cancer, because by the time we find it, it's usually pretty advanced. So some of the clinical manifestations of oral cancer, not a lot of early signs, right? So the one thing to note is that all of the cancers we talk about in this video are serious and sad and devastating because they affect communication, speech, body image. So common signs and symptoms of oral cancer, again, one wouldn't think because they have an earache that they have oral cancer, but it could be a sign. A lot of the patients that I dealt with at Roswell Park, they came because they had toothache that didn't go away. Late signs are difficulty swallowing, chewing, speaking, and any tumor that's above 4 centimeters will often reoccur. So those are all the signs and symptoms up here. A little nod to HPV, that 51,000 oral and pharyngeal cancers from HPV as 2018 data. 10,000 people died, and that HPV-16 is what causes that. We do have a prevention for that. We can have Gardasil given. One thing to note, that cancer related to HPV, they do actually tend to do better than those whose cancers are not. So tongue cancer, let me move this guy over here, sorry. Let me move that over. So tongue cancer can also be quite disfiguring, and we need our tongue for speech and swallowing. It's difficult with tongue cancer. There's something we could do like a hemiglossectomy or a glossectomy, which is complete removal of the tongue, which leaves a lot of functional impairments. But again, the tongue cancer, because it's oral, tends to spread rather easily. So anytime we do reconstructive surgeries after dissections, we often use something called a free flap. And this is basically where we're taking tissue from the ulnar and radial area, and basically the tissue is removed from the arm using those arteries and put up to cover the neck or wherever else we are doing these dissections. So that is called grafting. And we may touch this again, but a reminder that when we're taking care of people who have grafts, we have graft care. And we have to make sure that the person maintains circulation to that newly grafted area. So that may be looking at Dopplers, checking the skin color and warmth. They should be a kind of normal body color perfused tissue. So if it's turning white, that means it's not perfused. Some of the nursing management for oral cancer. Again, they're very sad cancers, but we need to make sure that we manage the airway. Number one is always airway. Elevate the head of the bed. Help them with suction. Of note, we generally won't suction we try not to suction a brand new trach for the first, 24 hours or so, but suction, and if we do, we have to be very gentle because of the risk of bleeding, which can impair the airway as well as cause death just from if we were to possibly rupture an artery there. And then the graft care. So suctioning with care to prevent that graft damage. And then, so I did just talk about this, but post-op viability, what's it look like? Anything that looks paler than what the normal tissue should be is a sign that there's an arterial occlusion, meaning that the blood is not being supplied to the area. Most of our head and neck cancers die because of the mets to the other areas. And our head and neck cancers generally do not respond very well to chemo and radiation, but that's what we have, so that's what we throw at it. And as we move down to cancer of the larynx, so things that you can see the signs and symptoms here. Hallmark, hoarseness that lasts more than 2 weeks. They often complain of cough, feeling of a lump in their throat, difficulty swallowing is potential, pain radiating to their ear. One thing to note, that radiation can cause voice changes, and this is not to mean that somebody who's on radiation now has signs of, additional signs of cancer. If a person's undergoing radiation, important to note that their voice should improve 6 to 8 weeks after the radiation stops. So sometimes people are concerned about that, and we have to let them know. I only have a few more slides. This is a picture of the radical neck dissection versus modified. So what we see here are all these different muscle groups. So radical neck dissection moves all of those pieces. The difference between that and modified is that modified is more common, but it does remove all those cervical lymph groups, but then spares one of the structures. So radical neck, since it removes all of the people, these people are the ones that are left with a shoulder droop, and they are going to need physical therapy. All right, nursing care of the radical neck dissection. Basically, always, once again, concerned about airway. You're going to see that in respiratory. We're constantly worried about the airway. A person will generally have some drainage collection devices, usually JPs. And then if you see this picture there, that chyle fistula, see that doesn't look like what we would normally expect to get out of a JP drain. Normally it should be serosanguinous. But when we see that kind of milky white substance, it means that there's been a problem with the lymph system, so a lymphatic vessel. These usually accumulate in the thoracic or the abdominal cavities. So we'll see this. Sometimes people who have chest tubes, we might see that because of lymphatics. We might see it in head and neck surgeries. Oftentimes, these people need to go back to the OR to close off that lymph system. You need to let the doctor know right away. Nursing generally doesn't change the initial dressings. We reinforce them. However, we may with doctor's orders. Because of the need to frequently assess the graft dressing, unless they have some sort of implanted Doppler, so we call it an internal Doppler, the graft is usually left where it's visible so that we can make sure it's perfusing. Antibiotics are needed to prevent infection and so that the graft has a chance to heal. And remember that we use absolutely aseptic technique when cleaning the skin and working with these patients. So a quick recap of head and neck cancer. We've already kind of gone through all of this with cancer, but you could always go back and look at that. But radiation, common to use the external beam or internal. Chemo and targeted therapy can be used here. A reminder that when we're dealing with head and neck cancers, nutrition is definitely impaired. So these people generally have a PEG tube or just a G tube. So PEG when it's first put in, G if it's re-put in. And then to remember that people who have chemo and radiation, what we're going to see is based on the treatment that's given. We need to make sure that we're monitoring weights, checking their ability to swallow if they're on a diet, and also if they're on tube feeds. Remember that just because a person has tube feeds doesn't mean that they are at decreased risk for aspiration. In fact, often they are at increased risk. And then, of course, communication with the TEP valve. We continue on here. Poor dentition is one of the reasons that they sometimes will postpone radiation until the teeth are extracted. Person should use fluoride to strengthen their teeth. So concerns about nutrition and communication are here. It's okay to use baking soda and warm water. Baking soda doesn't require a specific doctor's order, interestingly enough. We have to worry about communication. It's one of the first things we need to establish is how to communicate with a patient who's had this. Pre-op teaching goes a long way. Might use things like alphabet boards, pictures, and nowadays people are pretty adept with their cell phones. So I've had patients type what they want and then have their phone say it out loud for them. So technology is really helping. And then as far as management of the patient as well, there's disturbances in body image, and we have to always be concerned about whether or not the person is accepting, and how can we tell that, right? They're participating in their own care, they're learning, they want to be involved in the process. So we have to be concerned about those that potentially aren't. And then pain. So certainly all of these that are listed here are great for pain. We need to make sure that we are helping our patients with their pain management and advocating on their behalf. So you can pause and look at all that. And a little review about laryngeal cancer. So kind of falls under the head and neck cancer, but if it's early cancer, we try to spare their voice. So we might do like a partial laryngectomy. And if that's the case, the patient tends to do better. However, remember, most cancers aren't caught early, they're caught rather advanced. So oftentimes we might go to a total laryngectomy that could potentially give you a cure if it's advanced. But of course, we might use it if there's a recurrence or persistence of cancer despite our treatment. In this, the laryngeal structures are removed. So remember, these people are obligate neck breathers. It is recommended that they always have a medical alert bracelet and that they have alternate means of communication and special signs, which we'll talk about in class. And then remember, these people have a permanent loss of voice. That doesn't mean that they won't be able to speak, but it will never be normal. Just like a trach isn't normal, this is even less normal. TEP valve would be the most common here. And a little nod to tracheostomal stenosis. Remember that this is always a risk for anybody who has any sort of artificial airway. So it could be narrowing of the stoma. It could be at the actual stoma, at the skin. If that's the case, then basically we need to measure this. Person needs to measure even when they go home to make sure, and this is why people often will have the trach tube, or the Larry tube as they'll call it in the case of a laryngectomy. One of the biggest reasons that people get tracheostomal stenosis, though, is excessive traction and high cuff pressures. So ensuring appropriate cuff pressures becomes very important for these patients. And then carotid blowout syndrome, something that I think that you need to know about. It can be caused by an erosion of the tumor into the carotid artery. People with head and neck cancer, they would be at high risk for this. Also, people who have had a surgical procedure on the carotid artery would be as well. Come from actual radiation. So somebody who's got bleeding after radiation, they need to be assessed. When we have a carotid blowout, that happens that when the carotid artery actually blows. Imagine the loss of blood and pretty immediate loss of consciousness. If this were to happen, you apply direct pressure, get help, understand that even if the folks were to survive this, many are left with severe neurologic abnormalities and disability. But it's something to be aware of, direct pressure. And then our discharge teaching is here. So this is basically everything we talk to our patients about. There's the medical alert bracelet. Basically, one of the most important things is in the event of emergency, they are neck breathers. They cannot be ventilated through their mouth and nose because there is no longer that connection. And then, of course, maintaining moist air. Many of our patients, whether they have trachs or laryngectomies, will often have a trach collar with humidified air, so even if they don't need oxygen, especially in the early days, before their body gets kind of used to it. Because that's one of the things we always need to be concerned about, is making sure that the person's airway remains patent and doesn't get filled up with thick crust. All right, guys, so this is has been part 1 of respiratory. Thank you.